I would now like to welcome our speakers. So our first speaker we have is Dr. McWhirter. Dr. McWhirter is a staff medical oncologist at the Zawadzki Cancer Center in Hamilton and an associate professor at McMaster University. She received her BSc, MSc, and medical degrees from the University of Toronto. Training in medical oncology continued in Toronto, and she completed a fellowship in investigational new drugs at Princess Margaret Hospital. Her interests include new drug development in melanoma and gastrointestinal cancers and melanoma prevention. Professional memberships include the Melanoma Executive Committee of the National Cancer Institute and the Melanoma Disease Site Group of the Cancer Care Ontario Program in Evidence-Based Care. And she's the local PI on a number of international clinical trials in melanoma and GI malignancies. Along with Dr. McWhirter, we have Annette Cyr joining us tonight. And Annette Cyr is the chair and founder of Melanoma Canada and three-time melanoma survivor. So I welcome both panelists to the screen.
Good evening, everyone. Thank you for joining us tonight. Annette and I thought it might be a little bit of a different format to have a chat about some of the really exciting updates from the Canadian Melanoma Conference this year. It's a small conference. It draws some amazing international speakers. There's some really very informative sessions, both from patient perspective as well as for clinicians. So we thought we would talk about some of the highlights from this year's conference.
Thanks, Elaine. I thought we'd start off by asking you, putting you right on the spot. What has been some of the most recent developments in the last year for melanoma? What have you seen happening for our audience?
Yeah, so I think one of the big new treatments that we're seeing coming out is with regards to uveal melanoma. So melanoma of the eye has been a notoriously difficult subtype of melanoma to treat. It is very different from cutaneous, or what we call skin melanoma. It has different genetic abnormalities. You don't, for example, have BRAF mutations in uveal melanoma. And though, we do see, fortunately, some responses with immunotherapy, it is not as effective in the eye as it is for melanomas that start on the skin. And so one of the, really exciting things that has come out is a new drug that's been studied for this and is currently being evaluated by Health Canada and the groups that move new drugs forward into patients. So there was a fairly large trial done. It was just published this year in the New England Journal of Medicine. It was a phase 3 trial, pretty big, 378 patients, and they were randomized in a 2-to-1 fashion. That means for every 2 patients who received the tebentafusp, which is the name of this new drug, 1 patient would receive what was called investigator's choice of treatment, and that would either be chemotherapy with dacarbazine, a very old drug from skin melanoma, or immunotherapy with single agent pembrolizumab or nivolumab. Similar to the chemotherapy and the immunotherapy, this is it's an intravenous drug. It's an interesting mechanism. It's specific for a type of uveal or type of patient that has HLA-A*02:01 positivity. In North America and Europe, that's probably about 45% of the population. And the reason why this is important, an important test that has to be done ahead of time, because in the mechanism of how this drug works, it uses this HLA-2 to bind to the target cell or the cancer cell. And then it has a second receptor that binds to cells of our immune system that get that immune reaction response going, which creates more cells from our immune system and other factors in the blood, something called cytokines, that really get the immune system ramped up, specifically in this type of cancer. For this study, all the patients had no prior treatment. And it's a little bit different in terms of what we're usually used to with immunotherapy. Patients out there who are watching tonight, maybe some of them are on treatment. They know that the scheduling tends to be every 4 weeks, or maybe sometimes every 2 weeks, or 3 weeks, or 6 weeks. But you don't come in overnight. And because of some of the side effects we see with this drug, there is an overnight admission after the drug administration. And that's usually as they titrate up the dose. So the first dose is the lower dose, and then a second dose, and then the third dose is the target dose. And the reactions we can see are related to that increase in cytokines, and that can cause sometimes things like low blood pressure, and that's why we need the overnight observation and admission. Certainly very treatable with intravenous fluids. We can also see some other things like rash and itchiness and sort of flu-like symptoms. What was really impressive here is that we saw a really significant improvement in survival at 1 year in favor of the tebentafusp, 73% of patients versus 59% of patients in the other arms. And I know this is a fairly early publication. Definitely when you have something that's this exciting, you need to get the news out, but I'm quite sure that over the coming years, we'll get updates on this drug. Just to finish this off, I thought I would show a graph that is looking at the survival of patients who were treated with tebentafusp. That's the yellow line. And then the control patients who were treated again with either immunotherapy or chemotherapy, though most of those were with immunotherapy. Back to you, Annette.
For pembrolizumab, as you know, Keytruda or pembrolizumab has been approved in Canada for quite a few years now for metastatic melanoma. And then it moved to the advanced stage, 3 patient community. But the interesting thing now is that we're looking forward to the stage 2 B and C melanomas. And I'm wondering if you can explain to us why this group now has a particular need, or what has been shown as far as stage 2 melanoma.
Yeah, thanks, Annette. So yeah, definitely this is another highlight of recent advances in melanoma. Melanoma staging doesn't work. The staging system, I should say, which is something called TNM, and T stands for the tumor, which in the case of melanoma is how deep it penetrates into the skin. N is the number of lymph nodes involved, and M is metastatic disease. And it's been known for decades that actually patients who have 2B or C melanoma have a higher risk of recurrence and dying from melanoma than patients who have stage 3 disease in the setting where it's one microscopically involved lymph node, so something that would be found at the sentinel node setting. So patients with stage 2 melanoma that are higher risk, that's the stage 2Bs and Cs, their melanoma is at least 2 millimeters in depth and ulcerated, or it's over 4 millimeters in depth and ulcerated or not. They've all had a sentinel node procedure and it was negative. And so really it has been an incredibly long time in coming that these therapies have moved forward to these high-risk patients. So this was presented just last fall, again, a phase 3 trial, big trial, almost 1,000 patients with stage 2B or 2C melanoma. And the patients are randomized to pembrolizumab or placebo for a year. It was what's called a blinded study. So neither the patient or their physician knew which arm they had been allocated to. And when the results of this were analyzed and presented, we've seen a significant improvement in recurrence-free survival at 1 year in favor of pembrolizumab. 90.5% of patients alive and well versus without a recurrence of their melanoma versus 83.1% of patients who received a placebo. And again, placebo or no treatment, surveillance of patients is standard of care. There's not been treatment previously to offer in patients with high-risk stage 2 melanoma. So really very impressive result.
So not sure what your next slide has, but I wonder if you had any data on the Nivo combo, the original combination immunotherapy. And I know there was a 6-year update on the efficacy of that drug therapy. I wondered if you had some commentary on that.
Yeah, so let's, so I mean, this is just a brief description of what you're looking at here. It's a CAT scan, and this is the liver, and we see a whole bunch of round dark spots, and the liver should not have those round dark spots. This is stage 4 or metastatic melanoma. And yes, as you mentioned, Annette, another highlight from last year was the update of the combination of 2 immunotherapies, which at the present time is only used in the stage 4 or metastatic setting. So this is the last time we saw an update. It was at about 5 years. And I think really one of the most exciting things to see this update just at a year and a half later is it's showing us that it looks like patients who have stayed alive at 5 years are continuing to stay alive and well, because the 5-year survival for patients who are treated with ipi/nivo was 52%, and we're really still sitting at that, 49%. So we're not seeing a lot of loss of patients. Again, this will continue to get followed, but if we look at the earlier data that we had with the ipilimumab when it came out as the first immunotherapy for melanoma, we knew that once patients lived for were still alive for a few years, and then we looked out at them in 5 and 10 years later, and they were still doing well and alive. So I think we're starting to see a signal here that survival curve is leveling out, and it's so important for patients to see that, who are getting into that 5-year range out from this time frame is from you first started your treatment with immunotherapy. I think this is really very encouraging news for our patients to see that if you are making it out to 5 years, it looks like you might be good for quite some time into the future. The nivolumab, again, there certainly are situations where the combination of ipilimumab plus nivolumab might not be appropriate, or patients may not be interested in the combination, because unfortunately there is a lot more side effects when we combine the 2 immunotherapy drugs together compared to giving one drug on their own. So for the ipi/nivo combo, that serious side effect rate is around 60%. And when we're looking at nivolumab on its own, it's about 15. So unfortunately, there are some trade-offs there. But again, the wealth of experience in treating our patients with these and knowing what to look for in terms of side effects, and educating our patients to tell us about side effects and getting them treated, I think makes this a lot more manageable.
I was just having a little historic moment thinking back to just the time when IPI was the first approved, therapy. We had the BRAF therapy come out at the same time, but us thinking 23% was pretty darn good at that time. Mm-hmm. So I mean, it is. I know for some it's certainly not enough yet, but we've certainly made progress in the last 5 to almost 10 years. It was 2011, 2012 when those first ones got approved. So I guess we're hitting on the 10-year mark on this. So even at 50%, we'd certainly like to see that number go up, and hopefully with ongoing trials and such, we'll have even better results to look at in the future. But so that's really good news for the combination, and even nivo on its own is certainly quite acceptable and positive. But we do have another BRAF combination therapy to talk about, and wondered if you can all give us some insights into that. And sure. First of all, what's the BRAF mutation? A lot of people won't even understand what that.
That's a fair question. So a BRAF mutation is not a genetic or inherited mutation. It's something that is inherent within the melanoma itself. And we know in the North American population, probably about 40 to 50% of patients who have melanoma have a BRAF mutation. And that's a little bit in contrast with, say, Australia, a little bit more sun exposure, and that's in the 50s to 60% range there. And basically, it's a growth pathway that's normal in these cells, but when this protein in the growth pathway is mutated, it's like it's got the growth switch stuck in the on position and it can't turn off. And so what these drugs do, these are so-called designer drugs, they're very specifically made to bind to that abnormal form of the BRAF protein to take it off the on switch and flip it to off. And what does that mean for patients? Well, the cancer cell dies. Okay, so this is, I think it's really exciting. Again, in terms of treatment options for our patients, this is a newer combination. It has passed what's called PCODER, which is the national approval body has said, yes, this drug should move forward. And really what it gives patients and physicians is choice, because there are certainly some differences in the side effect profiles of all of these combinations. So presently we have vemurafenib plus cobimetinib funded. Really, the most patients are treated with dabrafenib plus trametinib based on its side effect profile. But there's still some side effect differences between all of these. And I think this is really important to be able to give our patients choice and tailor the combination to one that may suit them the best.
I guess one of the differences as well is this is most of the, I think all of these BRAF inhibitors are oral drugs versus,
Yes.
So they would be take-home therapies, and for some that makes a difference. You don't have to travel in and
You're right. Yeah,
so.
they are they're home medications, not intravenous.
Good.
One important thing to note though is none of these there's been some little comparisons between 2 and 1 drug, but these 3 combinations have not been compared head to head as combinations. And when I'm saying combinations, so the one drug inhibits that protein with the mutation. We talked about the BRAF, but as you can imagine, there's a whole pathway of events in terms of a cell growing or stopping to grow. And the drug that these are combined with is something called a MEK inhibitor, and that's basically just the next step in the pathway. We realized if we block that growth pathway not once, but at 2 places, then we have a more effective combination.
So just on that one note, before you go into the basal cell, it must be quite complex to determine what therapy to offer patients. I guess if, obviously if you're a BRAF positive, meaning I guess you've been tested, and are all patients now tested that come in to see you for the BRAF mutation, or is it cut off at that stage 3 still?
No, so this was mandated by CCO, I think over a year ago now. So all of the 2BCs, it's something called reflexive testing. So when the tumor sample goes to the lab, it should automatically get BRAF testing done.
So all 2B, C, and up go through that. And how do the oncologists make a determination what's the best pathway to follow? What is there anything that you look for in particular?
I mean, there's several factors. I mean, certainly number one is always patient preference. We certainly have to discuss the scheduling and the side effects. So immunotherapy, intravenous, and has its own set of side effects. The BRAF targeted therapies are pills with different side effects. There is some data that it's from a type of study called a retrospective study. So when we've sort of looked back at patients who've been treated with BRAF inhibitors, there certainly seems to be some groups of patients who have a longer response. So most people will have a response to this combination, to this type of combination. The challenge is that in some patients, that response may only be a few months. And in other patients, it can be very long-term in that sort of 5-year plus range. So there are some features that we look at in terms of that selection. How much tumor does a patient have? Sort of how many different places do they have metastatic disease? And there's a blood test called the LDH. So, and whether or not patients have brain mets. So there are a few factors that can help us decide. Again, and this is when you're going to do the first drug, patients who have been treated with a BRAF inhibitor are still eligible to have immunotherapy. So, there's 2 potential lines of treatments in that setting.
That's good to know. Excellent. So I guess on to your next slide and such. Have there been any advancements in the treatment of other skin cancers in this past year?
Yeah, so I think we would clearly all agree that this is a very advanced and most unfortunate case of a basal cell carcinoma. I think what's really important to realize is that these start as tiny cancers, and they just need to be seen and treated early and removed, and they're very, very curable. But occasionally, for various reasons, patients don't present until they have something that's quite large and can be disfiguring and painful. It's very difficult for patients. And so, we have had an oral therapy that's been quite effective for patients who present with these advanced basal cell carcinomas. It's quite rare that this type of tumor would metastasize. So, for example, to spread from the skin into the lungs or the liver, but very rarely it does. In the first line of therapy that we have, it's a class of drugs called hedgehog inhibitors. While they work for many patients, again, in some patients they may not work, and in some patients they may work for a period of time and stop working. And in some cases, there can be challenging side effects with that pill form of therapy, and there's a need to switch. And so what's one of the really exciting things here is we do now have another line of therapy to offer patients who've already had a hedgehog inhibitor. So that's a drug for most patients would be something called vismodegib, but there's a cousin drug as well called sinidegib. If they have to stop that therapy, that we now have something to offer. So cemiplimab is immunotherapy. It's a PD-1 inhibitor, and it's been studied in basal cell cancer, again, in the setting of patients who've already had a hedgehog inhibitor. Locally, so very advanced or metastatic basal cell, again, is a very rare cancer because fortunately, most of these patients will be cured of this type of skin cancer. So it's the much smaller numbers for the trial. So 84 patients, they received this medication intravenously every 3 weeks. And 31% of patients had a response, which is really going from having no therapy to offer. I mean, we only had the hedgehog inhibitors. To have almost a third of patients responding to another drug is really wonderful. And a proportion of those, about 6%, had a complete response.
That's amazing, and it is difficult, as you say, with basal cell that has metastasized. It's rare, as you say, but it does happen, and I think that, I'm not quite sure of the numbers, but I think it's somewhere between 700 and 1,000 cases annually that end up metastatic in the country, and of course that's compared to about somewhere in the neighborhood of 80,000 cases of basal cell, diagnosed every year in Canada. Fortunately or not fortunately, we don't track the numbers in Canada because of this. It's considered perhaps it is easily treatable if you get it done. And I think a lot of people online would know themselves, or maybe their parents or grandparents and such, going in and getting these things burnt off or excised and or treated topically. But obviously important to not only get things that are looking a bit strange or changing on your skin checked, but those preventative measures, because you can speak to this very, very well. But one of our main beefs as an organization is we still need to have so much more knowledge about sun safety and sun awareness in this country, taken far too easily, that we should get out there and bake. And I do remember you very, very sincerely saying we need to start sun safety a lot earlier, and springtime being the key message time when the rays of the sun, although we're drastically needing some sunshine, at least here in Ontario, it's been a gray and cold and overly burdensome snow winter. But I think heading into spring months, where we start seeing the UV index going up, a lot of people, in their anxiousness to get out there and get some fresh air and exercise. Still when it's cold. I mean, we can associate the cold with not having to wear protection. But if you're outside gardening or walking or, bicycling or, whatever it is you're doing outside, those rays are very strong. If you're out spring skiing, I mean, I remember as a young adult teenager skiing in Banff and out west, and the intensity of the sun rays and getting burnt and saying, well, it's windburn, but it's not. There's no such thing. It's absolutely amplified rays off of the snow and ice. And so just wanted to get a plug in there for everyone for a bit of sun safety and sun awareness. It's great to get outdoors and get that exercise, and God knows we need it after what we've been through for the last few years, but sun protection number one while you're doing that too. So wanted to get that in. Well,
definitely hit the drugstore and stock up on your sunscreen, because of course you were already wearing a daily SPF on your face, so now you just need to start covering up the rest as the layers peel off.
Yeah, exactly. Wear a hat, wear some sunscreen. Okay. And so following this onto the next slide, unless you've got anything else you want to comment on there.
No, I don't. I might have a graph there, but yeah, let's go on to the next slide.
Okay. So we've all, we've talked, I've heard a lot, certainly on the news, of the mental health aspects of COVID and what being shut in has done. And I've also experienced it as a patient going down to Princess Margaret at the start of COVID, and, not having anybody to go in the hospital with, going through all sorts of testing procedures. I have a good taste of that. I can't imagine being a new patient again, going through it. At least I had some knowledge and armed, with what was ahead of me. But I'm just wondering if you could comment briefly on, what you're seeing as a result of COVID, and what the impact has been on melanoma and skin cancers in particular. Certainly there's applications across other cancers as well, but what you've seen and what you think are some of the primary issues that we're facing.
Yeah. So, again, I think across the board, the mental health aspects of this, a cancer diagnosis is difficult enough. To not maybe have someone in a visit with you, or a lot of our visits were by the phone. I really think there's a lot lost in communication when it's just on a call. But that's significant, and I'm sure, all right, I know certainly our organization has had an increase in calls related to the mental health burden of COVID on patients and the isolation. But the tough part of what we're seeing is, especially with some doctors' offices being closed, or a fear of going out and going for that visit, that there's been a delay in diagnoses. And there's some really good data to support that. If we go to the next slide. It's a publication from Tim Hanna, who's a medical oncologist in Kingston. And so if we look at the orange bars, okay, so let's take a step back. So this is the number of biopsies along the left, along the left, and these are as we head into the months of COVID. And the orange bars are the number of COVID diagnoses. And so we can see with the light blue line, this is any skin cancer diagnosis, and we hit like the numbers just coming up in COVID, and there is an absolute plummet in any skin cancer diagnosis. This has been mirrored across other countries. This has been mirrored across many other cancer sites, but there is some data published that skin cancers in particular have taken a much deeper dive down in terms of lack of diagnoses compared to some other cancers. And so if we look at this light blue line prior to COVID 2019, there's ups and downs, but the overall rate of diagnosis is much higher. And, as we've had some gaps in terms of the which wave of COVID we're on, we can see that increased number of diagnoses again. But, this was published last year, and there's been additional waves, and unfortunately, we still have those dips, and we have to catch up, because the skin cancer didn't disappear. The sun didn't disappear, and all of these skin cancers are coming. If we go to the next slide, we'll look at melanoma specifically. And again, coinciding with the onset of the numbers going up, a huge decline in the diagnosis of melanoma. I think fortunately here we maybe saw a bit of a rebound in making up for some of that, but the general feeling is we are still going to have new diagnoses to make up, and also seeing patients present at a later stage, and whether that's with melanoma or more advanced basal cell and squamous cell cancers. Again, those cancers that should be easily curable when caught and removed, or treated when they're very small.
Well, that must have been, we are certainly expecting this wave of the undiagnosed, and as you say, the advanced cases, because the longer you delay seeing someone and having it detected, of course it continues to grow, and may not be growing necessarily on the surface but underneath, and so I'm sure, unfortunately, you're going to see more metastatic or advanced cases down the road. So certainly something that we have a great deal of concern for, and I'm sure certainly the medical community as well. So, and we feel for the medical community, because somehow we're going to have to cope with the additional stresses and strains that this is going to put on the system. So,
and I mean, we are provincially, as I'm sure other provinces are, coming up with strategies to get some sort of rapid access diagnostic procedures done. And certainly enlisting our colleagues, our family physicians. We've got a training module out in terms of being comfortable with skin biopsies, really anything that we can do to get patients diagnosed.
Absolutely. Very, very key, very key. So, given this state of affairs, from your perspective, what are the most pressing needs for melanoma patients in the next decade, or 5-10 years out? What do you think we need to do to help stave off and maybe see a downward trajectory instead?
Yeah. So I think one thing that's certainly very important is clinical trials. I mean, this is, we have some wonderful numbers. We know that a decade ago, maybe only a quarter of our patients lived for 1 year, and 10% at 2 years. So we know that we've, with immunotherapy and clinical trials, that numbers, as we said, is, up in that 50% range, which is really wonderful, but it's not 100%, which means there's more to do. And again, I really have to, incredible depth of gratitude to the patients who go on to clinical trials, right? This is how we advance treatment and get better outcomes. So, we have the pharma companies out there researching, and then when the drugs come down to the clinical trial stage, we need patients to put on, and it's really wonderful. Often the enthusiasm that our patients have to go on a clinical trial, and it's so appreciated. I think really what we're looking at is early detection is key. And so we talk about the ABCs, and I know you're well versed in this as well. But for our patients out there, and again, any of us would take any opportunity to do this education with our patients. So A is asymmetry. If you were to cut this mole in half, the two sides look quite different. So that's abnormal. B is the border. That's quite ragged and jagged. It should be nice and round and smooth. So that's an abnormal mole. Color. So we can see multicolored. There's areas of dark. When we see black, that's concerning. This mole looks like it's had a bite taken out of it. So where there was color and it's gone, that's also concerning. Blue is another concerning color. A spontaneous blood blister. So unless you have a story of closing your thumb in the car door, blood blisters should not just pop up on the middle of your arm. And so certainly a scenario like that, or a mole that's bleeding, really needs urgent assessment. Diameter, something bigger than 6 millimeters, about a pencil eraser. And then E is evolution or change over time. So it's having some of these ABCs, or it's elevating. So maybe you've had the mole for a long time and it was flat, but it's getting raised. And again, that's a scenario where you want to have it assessed.
All good scenarios, and all things we should be. And when in doubt, go see someone that might know a little bit more and be able to diagnose it as well. I'd rather be wrong
Yes, and we would rather that too, definitely. Yeah.
Okay.
We'd rather see 100 people who don't actually have a concerning mole.
There you go. There you go. So what has been the most difficult challenge for you in the past 3 years through this COVID experience of ours? What has been most challenging in your mind?
I know, I think virtual care has been somewhat of a challenge. I think there's a lot lost both for patients and clinicians in terms of actually seeing our patients and seeing people face to face, and um, see how they get up from a chair to a table or see what their weight is. There's so much to be gleaned from actually seeing a patient. There's been some helpful parts to that. Our patients who live far from the cancer center, and so we sort of walk them through that skin check or walk them through the potential side effects of their treatment. I think there's been some benefits there that I think need to be maintained practically, even paying for parking at the cancer center. But I do think, I think moving to, at certain points in time with this, we've been almost fully virtual. And I think that's been one of the challenges.
Well, like every coin, it's got two sides. And I think, there's been some incredible losses during this period of time, but perhaps some, as you say, gains in technology. And we got pushed into adopting some practices that perhaps we were a little bit hesitant in the healthcare system. So hopefully they can take the best of both and incorporate it and make it a better experience for everyone, going forward. So I just want to remind everybody too, before we take some questions, is that we have our national walk coming up. We used to do it in the fall, but we moved it to May as Melanoma Awareness Month, Skin Cancer Prevention Month. And that is coming up at the end of May. And we want to encourage everyone to participate. It is virtual again this year. We used to do it in person, and certainly was a lot of fun, and there was a good communal experience there. But with still the numbers of COVID quite virulent out there, and breakouts in certain areas. And also the length of time we need to get permitting from the various municipalities. It is remaining virtual again this year. So I would just ask for everyone to help us participate so that we can continue to do these types of things and offer these types of services. Much of our support comes from our patient community and sponsors, and zero from the government. So I'd sort of encourage everyone to look at paying it forward and doing what you can to help support us so that we can continue to do the great work that we're doing as an organization and meet the challenges of this disease. But once again, I want to thank you, Dr. McWhirter, for all that you do and all that you've been through. I can't imagine the level of work that you've had to endure. And I know, as one of our extremely valued board members, the contribution you've made to us and to moving physician education along and ensuring that the patient needs are met. So thank you again for all that you do for us. It's incredibly important work.
Well, thank you as well, Annette. I can't, it's hard to even imagine that for 10 years ago, there was no supports for patients with melanoma. And now there's this incredibly strong support system for our patients and education. Yeah.
So I guess to start us off, we we did chat a little bit about prevention. There was a question in terms of prevention strategies, and is sunglasses a strategy that should be considered to help prevent sun damage?
Yes. Yes.
Go ahead, Elaine. Go ahead.
Are recommended. There is the data isn't quite the same for ocular melanoma and sun, to be honest, but there is still felt to be some protection with a UV blocking glass and the risk of uveal melanoma. It's just we know there's a few other molecular factors at play as well. So yes, I definitely recommend sunglasses.
Yeah, I just add to that the number one cause of early cataracts is
Yes.
UV damage. So you don't want early cataracts.
Right.
Wear sunglasses. And, people can burn their eyes. I don't know. Oh gosh, he's on CNN, the guy with the blonde, super blonde hair reporter. He's always on there. He burned his eyes sailing a couple of years back and thought he was going blind and couldn't see for a couple of days. So yes, it causes sun damage for sure. So definitely.
So much. There is a question we have that came in pertaining to side effects, and wondering if there are any studies or how you support, Dr. Porter, patients who experience joint pain.
Yeah, so that can be a difficult one. It is one of the side effects that seems to persist for a longer period of time, despite the initial treatment for many of these is steroids. And so, for example, if your liver tests are off and you get a course of steroids, they typically recover, and if they get worse again as you're tapering the steroid, we escalate, and then in most patients it will recover. With the joints and the autoimmune inflammation, we typically wind up, if we get that recurrence after that initial course of steroids, we'll get a rheumatologist involved. And some patients do wind up going on the same type of drugs that patients with rheumatoid arthritis out in the community who haven't had immunotherapy would be treated with. Our group is actually at the Cancer Center are researching into some of these long-term side effects. The data out there is actually quite poor, and I think it's very important for patient consent and patient education, and to educate other physicians. The persistent toxicities from these drugs is real and not terribly well reported in the literature.
Is there anything new for treatment with BRAF?
I mean, we mentioned there's the newest combination. The data with what's called the triplet therapy, which is a combination of a BRAF MEK inhibitor combined pills along with a single agent immunotherapy. There's been a few of those studies with different combinations. For the most parts, the results have been, well, on a couple of them, they were negative, and one, it was positive, but it was a pretty small added benefit. So that does not appear to be the right direction for the BRAF mutated. So right now, it really is our BRAF MEK inhibitor combinations.
And I think we'll take one more because we're just coming on 5 minutes left. In regards to the Checkmate 067 study that you were discussing, someone is wondering, in terms of the data that you spoke about, is this just from one round of receiving the drugs? Is this continuous every year? Or how many rounds does this data show?
Yeah, so I mean, something we actually don't also have an answer for is how long to continue immunotherapy. So depending on the trial and depending on the drug, a lot of these trials were designed in what we'd call sort of a traditional chemotherapy model of treatment, which is where you treat it until the side effects were too significant or until the drug stopped working. But we know these drugs work for many, many years. And so typically we continue up to 2 years. Some patients may stay on immunotherapy longer than that. Some patients may come off earlier than that. We're actually studying it through the Canadian Cancer Clinical Trials Group. It's a Canadian designed and run study. Our Australian colleagues have joined on with us. So there isn't an exact right answer, but we usually go up to 2 years. And so the patients on the trial, again, this was earlier days of combination therapy. There was very rigid stopping rules. So if you had a very significant side effect after one dose of the combination therapy, you came off the study. I mean, now many patients will continue on off study, will continue on with the single agent nivolumab. The really encouraging thing is that they also published survival curves for patients who had to come off of treatment because of side effects, because it was protocol mandated. You have this side effect, no more treatment. And their survival curves are in line with patients who went on the treatment for months and even years. And I think that really tells us something. And it's part of the genesis of why we're studying it, because one, we don't know who needs one treatment and who needs 2 years, but it's an active area of investigation.
Thank you so much, Annette and Dr. McWhirter, for this very brief Q&A session, but we so appreciate you coming on board to answer some of those questions that we've had submitted. Here is our contact information. Please reach out to us. This is the toll-free number. You can also email and our website.